So here we are in the Foothills Emerge. My name is Gavin Greenfield. I'm an emergency physician, and I'm a STARS physician as well. And I have Chad Heggie here, who is a STARS paramedic. Been there for a long time. And we're going to demonstrate an awake intubation. Chad has some kind of upper airway obstruction that we are uncomfortable paralyzing him in the event that we can't rescue oxygenate him. If we paralyze him and then are not able to successfully rescue oxygenate him either with a bag mask device or a supraglottic, because his obstruction is still below those two devices, then we're heading towards the surgical airway, and that's kind of the classic indication for an awake intubation. So without further ado, we're just going to start. So the biggest thing with an awake intubation is topicalization, and so we're going to have Marika here, 1 cc of 4% xylo, and we're going to start with a nebulization first.
Good, thank you.
Yeah, and Chad, when you inhale, just if you can, kind of a quick inhale. Actually, the faster your inspiration, the more of this that rains out in the upper airway. And I'll just talk while we're doing this nebulization. What's the flow rate you have, Marika?
4 liters.
4 liters, so very low flow. We know that the lower the flow rate, the larger the particles that are generated, and the larger the particles that are generated, more of them will rain out in the upper airway. The smaller the particles have a higher chance of getting down into the lung. That's not where we want them. We're trying to anesthetize the upper airway. So so just 4 liters, and looks like we're. Marika, I'll let you tell me when it's completely empty here. Okay. And I'm interested, Chad, are you feeling any numbness anywhere in your oral cavity?
I think so, yeah.
A little bit, yeah? Okay. So next up, we're going to do 5% ointment. We have a tongue depressor here. This is a 6-inch tongue depressor. So half of the tongue depressor, 3 inches, single line of the 5% ointment. This is 1.6 grams, and when you do the math, that's 80 milligrams of lidocaine. So that is 80 milligrams of lidocaine right there. And we're going to start to massage that into the tongue. Specifically, the posterior part of the tongue. The anterior part of the tongue is fine. You can touch that all you want. You're not going to induce any kind of gag reflex. So I'm going to come in here. Just kind of massaging that into the tongue. And the other trick with this is put the lidocaine right at the distal end of the tongue depressor, so therefore your tongue depressor isn't going beyond where you've frozen, and in that scenario will be more likely to induce a gag. And that's it, Chad. You can just continue to just breathe, and you can hold that in, and you can even tip your head back a bit, and some of it will drip down into the deeper structures, which is good. That's what we want. And I'm just going to gradually work a little more posteriorly. And once we get around the curve, I'm going to grab some gauze. Okay, little gag there, and that's from the uvula, I think, what I just touched there. Leon, if you wouldn't mind opening that gauze there. And we'll kind of trap the tongue with that gauze. Yeah, that was the uvula I just touched there. And thank you. If you can stick your tongue out for me, Chad, thank you. Stick your tongue out there, Chad. Thank you. And we're just gently massaging that in. Jamie,
Yes, sir.
would you mind opening the, yeah, let's take a breath. Got a little bit left on this. Opening the unused atomizer.
1 second.
Yeah.
Okay.
Okay. The one that we haven't opened yet, the white,
Yep.
the easy spray. Okay, take a break. We have a tiny bit left of lidocaine on this.
It definitely,
Feeling some numbness? Okay. And then can we hook that up to some oxygen, please? At 8 liters a minute. Still not getting that back of the tongue. So we're going to, I think I'm getting the uvula a little bit, so I'm going to spray the uvula next. And I'll just dump it in.
just open it up.
We just have to open the lid there. And so we have 10 cc's of 4% lidocaine here, which is 400 milligrams of lidocaine. We're going to put that in there.
Can you hand me that container there? Thanks.
8 liters.
You okay? And just going to spray the uvula now, because I grabbed the uvula a couple of times. And just, is that okay?
Yeah.
Just a mist coming out of there. Okay. And you can turn that off for now, and we'll use some of that more in a second. Let's stay up on the table. Okay, so let's see if we can get any deeper down the tongue now. Excellent, excellent. So just a little more, just going further down the back of the tongue. And now I'm touching the uvula without much response, so that little atomization was beneficial for sure. And that was the tongue that got that, yep. And then,
Yeah.
and you can try not to swallow it. Hold it down there, and then when you have to spit, just let me know.
Okay.
Tongue depressors.
Lorraine, PCH.
Long way back there now. So that's 80 milligrams of lidocaine. We've used one of our tongue depressors. So now we're just going to nebulize. So again, this was 400 milligrams that started in here, Leanne.
Okay.
And now I'm going to aim at the palatoglossal folds where the tonsils used to be. A little bit on that side. A little bit on that side, and we'll just let that sit there for a second. And then this has a directional tip. This is a very simple device, just to, you put your product in here, and then and it doesn't have to be oxygen, air or oxygen flow, simply by depressing this button, it atomizes. If I've used the term nebulize up to this point for this device, that's not correct. It atomizes it, so it forms slightly larger particles, again, that will rain out in the upper airway. So I'm going to turn it down now, just to get some, and what I'll get you to do, Chad, is just as I go in, just inhale, just breathe in, and that'll direct this down to where it needs to go.
Okay.
You okay? You ready to inhale? Okay, go ahead. That's going to cause you to cough. Yeah, so that's normal. So good cough there.
Yeah.
How's it feeling?
That's fine.
Yeah. You get a little more there. Same thing. You ready to inhale? A little cough. Okay.
Yep.
So if we can we turn that off again, please?
Thanks.
So So just going to go back and we're going to pull that tongue out. I literally pushed right through Chad's uvula to get it back there, and there was no response. So he's getting some good anesthesia here. We're going to trap the tongue, pull it out as far as we can. If you can stick that tongue out, and then I'll take it. Now you can relax the tongue once I grab it. And I'm just going to continue with just a little more of this. See if we can get that down just a little more posteriorly. And then if you can just hold that in as long as you can, and then when you have to spit it out, we'll spit it out. And how are we doing on time? How long have we been doing this procedure, Leanne?
10 minutes, 34 seconds.
Okay. So I think it's time to see how Chad's doing, and we'll have a look here. So you can see that Chad's sitting in a chair. The newer stretchers, you can't stand inside the frame, so it creates difficulty. So I think a chair is probably optimal for this. And so we've got just a standard geometry 3 MAC direct laryngoscope. And Chad, if you want to just kind of open up there, I'm just going to gently put this in, and I'm just going to gently compress the tongue. So we're seeing posterior wall of the pharynx, and then you just breathe through your mouth, and I'm just incrementally going very slowly. Can I get you to tilt back just a little bit? Marika, can you pull on his right corner of his mouth for me? Putting a pretty good pressure on there, and Chad's tolerating this okay. Just small movements. Yeah, see that on the teeth? You okay? Yeah, okay. Thanks for that feedback. Yeah, little gag. Yeah, take that out.
Just give me a second here.
Was that did you have a gag there?
No, I just did this a little bit uncomfortable on my neck, actually.
Oh, with the cervical extension?
Yeah.
Okay,
'Cause
okay.
I think I'm going straight back
Okay,
as opposed to...
okay. Yeah, let's try and get you in a bit more of a traditional sniffing position.
Yeah.
So we're just going around the back of the tongue. You can see we got really good anesthesia here. And there's the epiglottis. And if you can take a big breath in, Chad, and there's his, so we have a grade 2 view. And let's just go down a little more and see if we can get right into the vallecula. And Chad is clearly tolerating this very well. There's the epiglottis. Take a big breath in. I felt that feedback on the teeth. I got that. Okay. So we had a good view of the epiglottis there. Could see the posterior cartilages and could see the opening briefly between the cords. Did you gag there, Chad?
No, I didn't gag, but there was pressure that I didn't like.
Pressure, yeah. And that's, so you can, once you get the patient anesthetized like this patient's anesthetized, you can do this procedure however you like. So I think I could have intubated him right there with what we saw. But let's try the glide, because there'll be less pressure on the tongue and in the vallecula. And let's see what kind of image we can generate with the glide scope. And you're not feeling, so you're feeling some pressure from me pushing, but as far as other airway protective reflex?
There's no gag, but yeah, just pressure.
Yeah, okay. Okay, so let's try the glide here. So now, hopefully you guys can see the screen. So you can see the epiglottis there, and there's certainly a grade 2 view of his cords. And Chad, if you can take a big breath in, so you can see how those cords will abduct when Chad does that. And why don't we, just for the purposes of the demonstration, is if I could have that tube, the endotracheal tube, and we'll just get it in the field of the view, and we'll show you how we could easily do this procedure. And we're not doing it today because this is purely a learning thing, but at that point, I would try and spray those cords a little more, and we'll get some subglottic anesthesia. How are we doing on time, Leanne?
You're at 16 minutes,
Okay.
10 seconds. Okay.
Probably around 25 minutes is where that anesthesia is going to start to wear off. Yes, please.
On the tube.
Sure. And then take a little bit on the side too.
Yeah. That way it comes off a little bit easier.
Okay, how you doing, Chad?
Yeah, I'm good.
Okay. We'll just generate that view. We're just walking down the back of the tongue, just compressing till we get in to see that epiglottis. There's the epiglottis. That's the nice view we just had. And then we're just going to bring this in. There's our endotracheal tube. And you can see I haven't turned it all the way anteriorly, but if I did that, we would bring it over here. And getting a little bit of response from touching his epiglottis. So I would actually come out and change the curvature on this a little bit. It's a little too curved, and make it a little straighter, so it would go a little more posterior. But there's the tip of the tube, and yeah, I'm very confident with a little extra anesthesia on the cords and the epiglottis and the airway itself that we would be able to intubate Chad either with this or with the direct laryngoscope. Yeah, thanks a lot. So let's go over how much lidocaine we just used. We used one 3-inch segment, so that's 80 milligrams. And we used kind of a third of the other, let's even say we used more, half of the other one. So 80 milligrams plus 40 milligrams, 120 milligrams here. Chad started with the nebulization of 1 cc, which is 40 milligrams. So that's, where's my math?
You're at 160.
I'm at 160 now. And then we used, how much of this did we use? We started with 10, and we have about 6.5 left. So let's say even 6, so that means we used 4. So 4 times 40 is another 160. So we used 320 milligrams.
Correct.
320 milligrams total dose of lidocaine. Toxic dose of lidocaine when it's applied to mucous membranes, we don't actually know. But certainly Chad's 80 kilos, so that's 4 milligrams per kilogram of lidocaine he just got to generate the view we just did. Lots of room for additional lidocaine, again, to freeze up the epiglottis itself, direct spray with the atomizer to spray the cords. Yeah, we had tons more room if we needed some more ointment for the back of the tongue. And Chad, so what was the worst part?
Just the pressure, I think. The pressure. So I think I was adequately numb, but there was some pressure. So I agreed that with some deeper topicalization, we probably wouldn't have been no problem.
Yeah.
Yeah.
Yeah. Any other comments from the team? I've got a team here, so yeah, we can thank Marika from RT. We got Jamie from RT. We got Daryl that helped us out the other day with the dry run for this, and Kelsey from RT. Phil's been a big help sorting out the milligram dosage of 5%. That's the product for the tongue, and this is probably the most important part of topicalization. Is this part right here? 5% is 50 milligrams per gram of ointment. So that's how we worked out exactly how much half of a tongue depressor is if you push it out in a straight line, being 80 milligrams. And we've got Leanne from nursing who is here ready to go with an IV. The biggest risk with this procedure, or a large risk with this procedure, and it's very, very small, but is laryngospasm. Anytime anything directly stimulates the glottis, and when I say glottis, we mean cords in the opening between the cords, you can have the chance that the cords will close shut. That's laryngospasm. So you do want to prepare for that. Leanne had RSI drugs ready to go in the event that we encountered that. One trick that's taught to our anesthesia colleagues through their training is mastoid pressure. So, as hard as you can, you push on those mastoid processes when the laryngospasm happens, and that will sometimes break it. This is a very small risk. And even if it does happen, it's usually transient and just resolves on its own. Of course, the advantage of the procedure is this patient is continuing to breathe throughout. This patient has obstructing airway pathology. When we keep him awake and we keep his brain connected from here to here, he's imparting a lot of tone to those airway support, the musculature that supports the airway, stenting it open as best as he can. And by not giving him any systemic medications, he will continue to do that. So, yeah, I think we can sign off there. And special thanks to Scott from the University of Calgary Cummings School of Medicine for helping us out with taping this. Thanks all, and thank you, Chad. And we'll sign off there. Gavin Greenfield here again, just a post-procedure discussion. We're just going to talk about lidocaine dosing to begin with. It's a question that always comes up. The literature doesn't really give us a good answer, and there is certainly individual variability in how much lidocaine is absorbed when you apply it topically. Numbers somewhere in the range of 7, 8, 9 milligrams per kilogram. I've heard anesthesia use the value of 12 milligrams per kilogram. We don't know, but what I think is important is that we have a methodical approach to how much we're going to use. The trickiest part is this. You'll notice on my tray here, I actually don't have the nebulization set up. I wanted to try that just to see. There is, my training has always been not to bother using a nebulizer at all. The particles generated from nebulization are very small and generally rain out in the lungs where we don't need anesthesia. We're trying to get anesthesia up here. I have done some recent reading, and it looks like, a really low flow rate. So we had that flow set at 4 liters per minute. That the particles generated are larger and may rain out, and preferentially some of them may rain out in the upper airway. The other thing that was interesting was the faster the inspiration, the more that rains out in the upper airway. So I just kind of wanted to try it. Chad said he got a little bit of numbness to kind of the back of his tongue with that. But in comparison to the atomizer, there was no comparison. So again, I'm going to go back to my practice of generally not using the nebulizer at all. But we did give him 1 cc of 4% lidocaine, which is 40 milligrams. 40 milligrams per cc, that's what 4% is. So we got 40 milligrams in the nebulizer. And then we went to the ointment. Again, this is 5%, so this is 50 milligrams per 1 gram of ointment. I went down to pharmacy and weighed all this out. This is 80 milligrams of lidocaine. It's about 1.6 grams of ointment. So 80 milligrams of lidocaine. So I prepared 2 of those. So we have 160 milligrams of lidocaine there. He then had 10 cc's of 4% in the atomizer. That's 400 milligrams, but we only used 4 cc's. So we have 40 milligrams with the nebulizer that we're not going to use again. We have 160 milligrams here, and we have 4 cc's times 40 milligrams, 160 milligrams of lidocaine here. So we use 320 milligrams. Chad's 80 kilos, so that's a 4 milligram per kilogram dose. By anybody's calculation, that's well within a safe dose. Interestingly, we tried this exact procedure with the reverse relationship. Chad's never done this, never done an awake intubation. He's an airway expert at STARS, but he's never done an awake intubation. And I wanted to demonstrate that this could be done on somebody's first try, just with sort of some coaching. Unfortunately, we didn't get there. That was a few days ago, but there was some great learning from that experience. And one of the things we did was we drew serum lidocaine levels on me immediately post-procedure, and then about an hour and 15 minutes post-procedure. And so I'm still waiting for those results to come back, but we'll have some interesting information when we get those results. But my total lidocaine dosing that day was actually, Chad was 4, I was in about the 9 milli, so more than double the dose, the per kilo dose than what Chad received today. And I was fine, symptomatically I was fine, but interesting to see what the levels show. So the other things that are sometimes used is this lidocaine. This is 10 milligrams per spray. It's actually 10%, but it works out to 10 milligrams per spray. So it's quite high concentrated. You're going to get to your toxic dose sooner. You don't need generally that high of concentration to adequately topicalize the airway. 4% is more than adequate, and there's been research literature published around that. I have it here, and we didn't use it. Just in the event that we had some difficulty anesthetizing the deeper structures, if we had some lidocaine in the bank, because we only use 320 milligrams, we potentially could have used this to spray the epiglottis, to spray the cords, just to even get some extra anesthesia, but only if you've got lots of room with your lidocaine dosing. So these devices, people are always interested in the actual atomizers. The two devices we have here in Calgary, this is made by Alcove Medical. It's called an Easy Spray. You saw how easy it was to use. You simply hook that up to 8 liters of either air or oxygen, and then just depress that. And then the other device is a malleable tip that just simply slips onto the end of a 10 cc syringe. So again, you put 4% in the 10 cc syringe. This just lure locks here, and this is directional. You can point it to wherever you want to go. So the usual routine is to spray the upper structures first, uvula, arches, palatoglossal folds, and then you're going to want to bend it down to get those deeper airway structures. And you could see Chad doing that as he inhaled. He coughed the first time. The second time he did it, he actually didn't have much of a cough, so we were already getting some very good anesthesia from that first atomization. So I think that's it for lidocaine. Oh, the other thing on this tray is this. I think this is very important. It's very hard for someone to voluntarily stick out their tongue and hold it out there. So just grab onto it, and you'll be able to pull it out quite far and get that ointment very, very, very posterior. Okay, so we'll end it there. A couple other points. You saw we were in a chair. I think that's the ideal position for a patient, unless you've got a stretcher that you can step inside the frame and get beside the patient. But these stretchers here have lots of stuff below the actual mattress, and you can't physically stand inside the frame, so it makes it quite awkward. You're either standing on the frame of the stretcher from above, or having to lean over, quite a bit from the side. So we use DL. I got a grade 2 view with DL, and we certainly got almost a grade 1 view with the VL. You can certainly do this with a bronch as well. Need training with a bronch. The exercise we're trying to demonstrate today is that this can be done with all the equipment that you are familiar with using. Checklist. So I think just like we have a checklist here in Calgary, we've got our airway management pause, it's referred to, but it's a formal checklist that we go through prior to every intubation that isn't a crash intubation. And I think it's very important to go through a checklist for this procedure. I don't expect you to remember. I'm not going to remember how much lidocaine that is, but it's on my checklist, and when I'm going to do this procedure, that's coming up on my device. And maybe we even evolve to, if we start doing this enough, to having a paper checklist. But have your checklist, so you have all your equipment. I mean, all your equipment is going to be very similar to your regular RSI checklist. I suppose the additional stuff is patient positioning will be different, obviously in a chair, and around the topicalization dosing. So that procedure took, Leanne was timing for us, and I put my laryngoscope in at the 8-minute mark, was the first time I put the laryngoscope in. And really at that point, we didn't have to add any further anesthesia. I certainly would have if I was going to pass the tube. I had that view of the epiglottis, and I would have potentially used the laryngoscope to facilitate more atomization. Although, you could certainly just do what we did in the video, put it straight back, turn the direction down, and just have Chad or the patient inhale for a couple more cc's, and I think that would have more than adequately anesthetized the cords, the epiglottis, the posterior cartilages. So we did that at 8 minutes. The whole thing took 18 minutes, but I think with a methodical, prepared approach, you can be ready to pass the tube certainly by 10 minutes. So as part of your preparation, you're going to want to know what to do after you get the tube. Now you're going to have some subglottic anesthesia, but when you're doing this, and that reminds me, indications to do this. When you're doing this for a patient that has obstructing airway pathology, once you've captured the airway, most of these patients don't have hemodynamic problems. You're not going to have issues with sedation. So you can have your sedation plus or minus your paralytics ready to go for post-intubation. And then as far as indications for this procedure, again, the classic indication is somebody with obstructing airway pathology. If somebody comes in with some kind of aggressive infectious process, but maybe a traumatic expanding hematoma, anaphylaxis would be on that list, although we have a very good antidote for anaphylaxis, so knock on wood, I've never had to intubate somebody with anaphylaxis. You want to keep those patients breathing. They are doing whatever they can to splint their airway open at that moment. And if we can allow them to continue to do that, we're not burning any bridges, so to speak. There is some thought that, just on a bit of another point here, sedation, so lots of people when you saw, we use no systemic medication here. And a true awake intubation is no systemic medication. It's pure topicalization. We want the patient to continue to breathe. We want them to follow commands. So we like to avoid sedation. There's a lot of what I call sedation facilitated awake intubation. And sometimes you'll just need to gather that little bit of extra cooperation. Fair enough. I think the big question you need to ask yourself, Laura Duggan is the one who taught me this from Vancouver. If you find yourself reaching for ketamine, ask yourself if you've adequately topicalized the airway. And I think that's probably the most common reason we do need a sedative agent to complete this procedure. But there is some literature, I've read at least one study, that says that, you know, the view you get, the view we just got with Chad fully awake, is not necessarily the view we're going to get if I gave Chad ketamine. If he suddenly interprets that life's good, he may lose a little bit of that tone. And yes, with ketamine, he's going to continue to breathe. But, well, certainly with ketamine, apnea is a risk. We do see it. But likely he's going to continue to breathe, especially in the doses we're going to supply to facilitate our awake intubation. But he may just lose a little bit of that connection from here to here, dissociation, or sorry, from here to here, and that view we got when he was completely awake and alert is not necessarily the same view we may achieve after we give him some sedation. We may just see a little bit of that obstructing airway pathology get worse. So ideally the procedure is done just under topicalization. The other indication, of course, is physiologic difficulty. All the pharmacology we use for patients has potential negative effects. And if we've got a profoundly sick, you know, cardiogenic shock patient or, you know, whatever hemodynamic catastrophe you can imagine, we may not want to give them systemic medications, and we'd like to maybe keep them awake. Anyway, thanks for your attention, and we'll see you next time.